Welcome to the iTech.net Basic Clinical Refraction course. This course requires some previous knowledge of clinical optics. If this list of clinical optics terminology is not familiar to you, iTech.net offers a course in clinical optics. The clinical optics course can be found at the web address shown on the screen. A refraction is an optical examination of the eye that uses feedback from the patient to determine the optical correction for the refractive error of the eye. An alternate term for refraction is refractometry. Refractometry is refractive measurements performed by someone other than an MD or an OD. The MD or OD takes the information available, either from their own refraction or refractometry performed by an assistant or technician, and uses his/her professional judgment concerning the physical state of the patient's eyes to arrive at a final signed prescription. A phoropter is the instrument most often used to perform a clinical refraction. This instrument houses a series of lenses that can be quickly moved into place in front of the patient's eye by turning wheels and dials. In special situations, a refraction can also be performed using a set of loose trial lenses and a trial frame. The techniques discussed in this presentation are based upon the EDTRS standardized refraction protocol for clinical research studies. This protocol has been proven to be accurate and time efficient for determining a patient's best corrected visual acuity. Performing a manifest refraction is a lot like working a puzzle. If the optics of your eye is perfectly spherical, the refraction would be relatively simple, requiring only a spherical lens to correct any refractive error. If everyone had a spherical cornea, we would all be able to pick up our cheap glasses prescriptions from a sales rack at Walmart, just like picking out simple reading glasses. Unfortunately for consumers, many human eyes are not optically spherical, but rather are astigmatic, making the refraction procedure much more complicated. An astigmatic cornea has two primary curvatures, 90 degrees apart, instead of the one overall curvature as found in the spherical cornea. Successfully refracting an astigmatic eye requires complicated instrumentation and a skilled examiner. On top of that, the human eye has a lens capable of changing shape. This shape shift is called accommodation, and it further complicates the refractive examination. The final glasses prescription often results in a sphero-cylindrical lens that must be custom-made. And of course, you will want a designer frame to show off your investment. The final tab for the patient is usually measured in hundreds of dollars. It should not be a surprise that a patient may be very unhappy if the new glasses are not performing as anticipated. It is possible to make errors during the refraction process. It is our goal to give you the tools to enable you to achieve great vision and comfortable glasses for your patient. As mentioned earlier, performing a refraction is a lot like working a puzzle. The more pieces of the puzzle you have, the faster and the more accurate your final approach to the solution will be. There are three main unknowns to every refraction puzzle: the sphere power, the cylinder power, and the cylinder axis. There are actually four parts, if you count the add power. Our goal, even before we start the actual refraction, is to be as close as possible to knowing what the final numbers will be. Where can we get this information? From four main sources: an autorefractor, retinoscopy, keratometry, and the patient's current glasses. For a discussion of the advantages and disadvantages of each, see the iTech.net advanced refraction video on the topic. For important advanced refraction concepts and techniques, such as listed here, go to iTech.net/refract for more information. Some of the discussion in this section may at first seem too obvious to mention, but if these details are not routinely checked, a price will be paid in terms of either lost time or a poor result. Efficiency is about doing a good job while keeping time spent to a minimum. Paying attention to details will keep you from having to repeat some time-consuming procedures when performing a refraction. The first thing you should do is wipe down the back of the phoropter with alcohol. While you are at it, go ahead and wipe down the forehead rest of the slit lamp and take the top paper off the chin rest, or wipe it if there is no paper. Do this in front of the patient. You will be surprised how many of them appreciate this, and many will thank you for it. You are already scoring points with the patient. Next, go ahead and dial in the numbers you obtained from the autorefractor, keratometer, or the patient's current glasses RX as a starting point. Do this before you align the patient behind the phoropter. If you had performed retinoscopy, these numbers will already be in place. You need to know that there are two different notations that can be used for a glasses prescription. One is called plus cylinder notation and the other is called minus cylinder notation. These two prescriptions are optically equivalent. The only difference is the notation method. The prescription on the top is in plus cylinder notation. Notice that there is a plus sign in front of the cylinder power, which is 150. The prescription of the bottom is in minus cylinder notation. Notice that there is a minus sign in front of the cylinder power. There are two types of phoropters, based upon the cylinder notation used. A minus cylinder phoropter has cylinder power numbers that are in red. A plus cylinder phoropter has cylinder power numbers that are in black. This is a minus cylinder phoropter. Notice that the numbers in the cylinder power window are red. The prescription notation must match the type of phoropter. If you put a plus cylinder prescription into a minus cylinder phoropter, the patient will not see well as you begin your refraction. After entering the prescription information into the phoropter, it is a good time to set the PD. The PD is the pupillary distance. This is the distance between the center of each pupil of the patient. The patient's PD should match the PD set on the phoropter. The goal is to align the patient's pupils with the optical centers of the lenses in the phoropter. The PD measurement might be obtained from the patient's medical record. The number can also be obtained by measuring the patient's PD with a millimeter ruler held up to the bridge of the nose. The phoropter PD is matched to the patient PD by using the PD window and the knob to the left of the window. An average PD number is about 64 millimeters. The phoropter can now be positioned in front of the patient. There is a forehead rest on the patient side of the phoropter that is controlled by a knob of the front. The forehead rest adjusts the distance between the patient and the back of the phoropter. The patient's eyes should be close to the lenses, but the cheeks and eyelids should not press against the back of the phoropter. The patient's head should be in a natural upright position. While performing a refraction, periodically check that your patient has not been sinking down under the phoropter. This is common with the older folks. They usually don't realize what is happening. A minute ago they were seeing 20/30 and now they can't see anything. Encouraging the patient to sit up straight usually gets them aligned properly. The next step in setup is to adjust the leveling knob so that the bubble on the level aligns with the dot. With the phoropter level you will be able to tell if your patient is level. If not, try to get the patient to cock his head to a level position. This is important for cylinder axis orientation. The final adjustment for phoropter setup is to be sure the phoropter is aligned squarely with the eye chart. You may need to adjust the angle while positioned behind the patient. Just before starting the refraction procedure, check to see that the auxiliary lens wheel is set to the open position on the eye that you are checking, and set to the occlude position on the opposite eye. It's frustrating to go through all the steps of refractometry and discover that both eyes were set to the open position all the while, because you will have to begin again unless the vision is poor in the opposite eye. Some refract with the room lights on, some with the room lights off, and some with the lights dimmed. Projected eye charts usually have plenty of contrast without the help of dim room lights. An advantage of having some ambient light is that you can better see the controls on the phoropter. Another advantage is that the patient's pupils are closer to their normal size. A large pupil size introduces more optical aberrations into the refraction process. In order for our patient to give us feedback, she needs to be looking at something that offers her the opportunity to discriminate between some visual choices. So we project something on the screen in her field of view. But what do we put on the screen? The recommendation is to initially put up an entire screen of letters, with the 20/20 line at the bottom. Ask the patient to read the lowest line they can read on the chart. Using the projector controls, isolate the line of letters just above the line that the patient had a little trouble reading. For instance, if our patient missed 2 letters on the 20/30 line, isolate the 20/40 line. As you proceed with your refraction, work your way down the chart as the patient's vision improves. An exception to this would be with the patient who can initially read 20/20. Keep this patient on the 20/30 line for the first checks of the sphere and cylinder power, and the initial axis check. If you are using a projector system, This is likely similar to your view of the eye chart. The letters appear backwards to you because mirrors are used to achieve a distance of 20 feet from the patient to the chart. The patient sees a normal image of the letters. You are going to be presenting your patient with a choice between two different lens powers or axes. Explain that to your patient. Explain to her that you want to know which choice gives the better vision. Give the choices names to aid communication. Many refractionists say, "Tell me which way is better, 1 or 2. Just prior to saying 2, the lens power or axis is changed. For the next series they may use 3 or 4 to avoid confusion with the previous choice. The standard order of testing for refractometry is as follows. 1. Initial sphere power check. 2. Cylinder axis check. 3. Cylinder power check. 4. Sphere power refinement. Remember to push plus. You want the most plus, or the least minus, for the best vision. If you leave someone under plussed or over minused, then they have to use some of their accommodative power constantly even to see clearly in the distance. This may cause symptoms of eye fatigue and will make it more difficult for them to read. Because you are going to push plus, you will always want to start with a change in the plus direction. This will save you time. If the patient likes the change in the plus direction, you will not have to do a check in the minus direction. These are techniques that help to control accommodation. Accommodation can create errors in the refraction process. More information on advanced refraction techniques, including controlling accommodation, can be found at itech.net/refract. The first check we are going to do is the sphere power. Remember that the sphere power is changed by rotating that big wheel on the side of the phoropter. Each click of the wheel changes the sphere power by 1/4 of a diopter. If your hand is moving the sphere wheel in a downward direction, then the power is moving in the plus sphere power direction. If your hand is moving the sphere wheel in an upward direction, then the power is moving in the minus sphere power direction. On this initial sphere check, present the patient with a choice of powers at least 1/2 diopters apart, which is 2 clicks on the sphere wheel. It is very difficult for most people to discriminate between 1/4 diopter changes. If the initial vision check was not good, for example 20/50 to 20/80, you might use 3/4 diopter changes, or even 1 diopter changes if the patient's vision was worse than 20/80. When you change the sphere power in response to a patient choice, change in 1/4 diopter steps unless you think you are far from the final result. This flowchart presents an example of an initial sphere check in the plus direction. At first glance, the chart looks complicated, but when you follow the explanations, the techniques will become more clear. There are 3 trials in this example, flowing from left to right on the chart. The starting Rx is plus 50-1 at axis 180, as indicated at the bottom of the first column, representing the first trial. Trial 1 starts at plus 50, as indicated by the blue arrow. The examiner says better 1, or better 2 as the sphere wheel is changed from plus 50 to 1 diopter. The examiner should pause briefly after saying better 1, before moving the sphere wheel. As indicated at the bottom of column 1, the patient indicates that her vision is better on the better 2 choice. That is, her vision is better with the 1 diopter lens. We now move to the second trial, as shown in the middle column. The sphere wheel is moved to the plus 75 position as the new starting point, as indicated by the blue arrow. Remember that we are giving the patient half diopter choices, and we advance the trial in 1/4 diopter steps. The examiner now says better 1, or better 2, as the sphere wheel is changed from plus 75 to plus 125 on the sphere wheel. Remember to pause before changing to better 2. The patient says the choices look the same to her. We now move to trial 3, in the last column. Even though the patient said the choices look the same, we are going to push plus. This means we will do at least 1 more trial in the plus direction. The new starting point is 1 diopter on the sphere wheel, as indicated by the blue arrow. The examiner says better 1, or better 2 as the sphere wheel is changed from plus 1 diopter to plus 150. The patient indicates that her vision is better on choice 1. Since we are now moving back in the minus direction, we can either leave the sphere power on plus 125 or on plus 1 diopter. This is the end of the initial sphere check on this eye. The final sphere power will be determined at the final sphere power check. This flowchart represents an initial sphere power check in the minus direction. As with the previous example, we will start with a prescription power of plus 50-1 at axis 180. Trial 1 is a reminder that we always start an initial sphere power check moving in the plus direction. The examiner says better 1, or better 2, as the sphere wheel is changed from plus 50 to plus 1 diopter. Again, remember to pause after saying better 1, so the patient can be aware of the initial choice appearance before the change. The patient indicates that her vision is better with the plus 50 lens in place. We now change to the minus direction. In trial 2, the better 1 position is the plus 75 lens and the better 2 position is the plus 25 lens. In trial 2, our patient indicates that she sees better on choice 2, with the quarter diopter lens in place. In trial 3, our better 1 position drops to the plus 50 lens as indicated by the blue arrow, but now we are moving in the minus direction. The better 2 choice is now the plano lens. In trial 3, the patient indicates that her better vision is with the plano lens in place on the sphere wheel. In trial 4, we will drop the better 1 choice to the quarter diopter position on the sphere wheel. The better 2 choice will now be the minus quarter diopter lens. In trial 4, the patient chooses better 1. We are no longer moving in the minus direction, so this is the end of this initial sphere check. We will finish with plus 25-1 at axis 180. The sphere value will be refined in the final sphere check. We have done an initial check of the sphere power and we are now ready to refine the cylinder axis and power. Although there are some other methods available, the cross cylinder is the most widely used for this purpose. The cross cylinder is quick and accurate in most situations. Like most refraction techniques, it works best when we are reasonably close to the endpoint. Again, we are reminded of the importance of a good starting point. Just as you did when checking the sphere power, have the patient view a line of letters that can be read, but is one line above the line the patient has trouble reading. But don't go below the 20-30 line. Rotate the cross cylinder into place. Begin by lining up the A's with your starting axis position. In this example, the starting axis position is 90 degrees. In this position, the dots on the cross cylinder will straddle the axis and will change positions when the wheel is flipped. Ask the patient which view gives the better vision as you flip from one position to the other. Just as you did when checking the sphere, identify each position with a number such as 1 or 2. This cross cylinder is flipped from position 1 to position 2 by using your thumb on one of the wheels. Let's say that our patient sees better on flip 2, with the red dot to the left. If we are using a plus cylinder phoropter, we will rotate the axis and cross cylinder in the clockwise direction, toward the white dot. This is called chasing the white dot. If we are using a minus cylinder phoropter, we will rotate the axis and cross cylinder counterclockwise, toward the red dot. This is called chasing the red dot. How far do we rotate the axis? That depends on our starting cylinder power. The larger the cylinder power is, the smaller your axis changes should be. For example, if the starting cylinder power is only a quarter of a diopter or a half a diopter, then initially rotate the dial 15 degrees. If the starting cylinder power is 3/4 of a diopter to 1 1/4 diopters, initially rotate the dial 10 degrees. If the starting cylinder power is above 125, then only rotate the dial 5 degrees. There is nothing magic about these numbers. The idea is to be efficient and to arrive at the final result in as few trials as possible. The point is that when the cylinder power is lower, it is more difficult for the patient to notice small changes in the axis. Once we have a new axis position, we repeat the process. The idea is to zero in on the axis that provides the sharpest vision by bracketing. The endpoint is reached when the sharpness on each flip seems about the same to the patient, or when the patient bounces you back and forth between two axis positions 5 degrees apart. For example, we begin with a 3/4 diopter cylinder correction at axis 90. We are using a plus cylinder phoropter, so we will move in the direction of the white dot. The patient indicates that vision is better on flip 2, with the white dot to the right of the A. We therefore move the axis dial in a clockwise direction. We will move the dial 10 degrees from axis 90 to axis 80. We will now repeat the cross-cylinder test by flipping the dial and asking the patient to tell us which flip, 1 or 2, has the better vision or sharper image. The patient again indicates that the vision is best on flip 2, with the white dot to the right of the A, so we move the axis dial another 10 degrees in the clockwise direction, from axis 80 to axis 70. The cross-cylinder test is repeated at the new axis position. The patient now indicates that the letters are clearer on flip 1, with the white dot to the left of the A. We now move the axis dial 5 degrees in the counterclockwise direction, from axis 70 to axis 75, which is our endpoint. We know it is the endpoint because testing at axis position 80 sent us in the clockwise direction. Testing at axis position 75 should lead to a response from the patient that the vision is about the same on each flip. Of course, we can position the axis between markings if the patient leads us that way. For example, a position in between the 75 and 80 degree markings would be recorded as axis 77 or 78. This would be much more likely when testing the higher cylinder powers greater than 1.5 diopters, which are more sensitive to small changes in the axis. If the endpoint axis is significantly different from the starting axis, you can double-check your work by rotating off-axis in each direction and testing again. For example, suppose your endpoint is axis 90. Rotate the axis dial to 80 and retest better 1 or better 2. The patient should choose the flip that leads you back toward 90. Now move the axis to 100 and test again. Again, the patient's response should lead you back toward 90. At this point we have performed an initial check of the sphere power and have used the cross-cylinder to refine the astigmatic axis. We are now ready to refine the cylinder power. This can be accomplished using the cross-cylinder or by simply using the cylinder power wheel by itself. As when checking the sphere power, have the patient view a line of letters that can be seen, but is challenging. If you use the cross-cylinder, rotate it so that the P's are lined up with the axis of the cylinder. When the wheel is flipped, the white dots and the red dots will alternately be lined up with the P's. Again, the patient is asked to identify which position gives the clearer image. If you are working in plus cylinder, the cylinder power is increased if the better view has the white dots aligned with the P's. The cylinder power is decreased if the better view has the red dots aligned with the P's. If you are working with a minus cylinder phoropter, the cylinder power is increased if the better view has the red dots aligned with the P's. The cylinder power is decreased if the white dots are aligned with the P's. The procedure is repeated until the two flips give about the same clarity to the patient, or until you start to go back in the other direction. In general, use the lowest cylinder power that gives the best vision. Cylinder power is changed by rotating the outer knob. In this example, the starting cylinder power is 3/4 of a diopter, and we are using a plus cylinder phoropter. The patient reports better vision on flip 1, with the white dot lined up with the P. We therefore would increase the cylinder power from 3/4 diopter to 1 diopter. We will repeat the procedure until the patient reports the choices look about the same, or until the patient indicates by her choice that she prefers that the power be reduced. In this example, the patient reports better vision on flip 2, with the red dot lined up with the P. Again, we are using a plus cylinder phoropter. We therefore would decrease the cylinder power. Many refractionists find it easier to just use the cylinder power wheel by itself instead of using the cross cylinder for cylinder power refinement. This technique involves using the cylinder power knob just as you would use the sphere wheel. For instance, if the starting point is plus 1.50 cylinder power, give the patient a choice between plus 1.25 and plus 1.75 by flipping between the powers with the cylinder power knob. If plus 1.25 gives the better vision, then present a choice between plus 1.50 and plus 1.00, and so on. Again, it is difficult for many patients to discriminate between choices 0.25 diopters apart, so give the patient choices 0.50 diopters apart most of the time. When you believe you have found the optimal cylinder power, it can be confirmed by bracketing. A trial in the plus direction and a trial in the minus direction, at equal distances from the optimum cylinder power, should lead the patient back to the starting point. An eye with very good vision may be able to differentiate quarter diopter changes. An eye with lesser visual acuity may require half diopter or larger changes. Using the cylinder power knob instead of the cross cylinder to check cylinder power is particularly useful if your patient does not have good vision. A good guideline is vision worse than 20/40. Most phoropters are equipped with a quarter diopter cross cylinder, which gives the patient a half diopter power difference when the wheel is flipped. When using the cylinder power knob, you can increase the diopter difference to whatever power you find to be effective. If you are making relatively large changes in the cylinder power, it is a good idea to recheck the sphere power in the middle of the process. This is called maintaining spherical equivalency. The idea is that you may be moving the circle of least confusion off of the retinal plane. For example, if you have made more than a half diopter change in the cylinder power, make a quick recheck of the sphere power before proceeding with cylinder power testing. If you are using a plus cylinder phoropter, you will need to check the sphere power in the minus direction. If you are using a minus cylinder phoropter, you will need to check the sphere power in the plus direction. Generally, we want to find the lowest cylinder power that provides the best visual acuity. Cylinder power that is greater than optimal may cause visual discomfort and/or distortion for the patient when wearing the prescription. We have completed the first 3 procedures in the order of testing. We are now ready for the final basic refraction procedure, which is sphere power refinement. Just as with the initial sphere power check, we want the most plus power, or the least minus power, for the best vision. You want to push plus, so you will always start the initial sphere power testing with a change in the plus direction. You will again be using the sphere power wheel. If the patient is seeing well, you can use quarter diopter changes to test. This will be one click when moving the wheel. You can again use half diopter or larger changes if the patient is having trouble discriminating with quarter diopter changes. You will use the same techniques that you learned when doing the initial sphere check. In the final sphere check, it is likely that you are very close to the optimal sphere power. If so, simply bracketing the sphere power may confirm the power as being optimal. There are additional refraction techniques that can be used to confirm and enhance the final result. These include cylinder power optimization, the red-green test, and binocular balancing. Binocular balancing is a particularly useful technique because it can be used to ensure that one or both eyes are not over-minused or under-plussed. It can also be used to ensure that the dominant eye has the better vision. Many patients are presbyopic, meaning they need bifocals, progressive lenses, or readers for adequate near vision. This tutorial does not include a discussion of the refraction techniques needed for these measurements. For information on the eyetech.net course that covers advanced refraction techniques, such as those listed here, go to eyetech.net/refract. This course on basic refraction has introduced you to the operation of the phoropter and to proven basic refraction techniques. The next step is to observe experienced refractionists as they refract actual patients in a clinical setting. There can be a wide variation in the techniques that experienced refractionists use. Not every refractionist uses the best techniques. Use the knowledge that you have gained from this course to take away the best advice from those teaching you. Be respectful of your colleagues who are offering to share their knowledge. There is more than one way to reach a good result. Refracting is part science and part art. One aspect of the art is learning what a patient will accept as a comfortable glasses prescription. In other words, what you measure might not exactly translate to the best prescription for the patient. Another important aspect of the art of refracting is being efficient. You want to be thorough and accurate, but you should also strive to refine your techniques such that the exam time is short. Patient fatigue works against you. All of this comes from experience and attention to detail. If a patient returns to the office with a complaint about the glasses that resulted from your refraction, you should be the one who evaluates the complaint and reaches a resolution to the problem. This is an excellent way to improve your knowledge of clinical optics and the art and science of refracting. The eyetech.net course on refracting has a section on a systematic approach to evaluating glasses complaints. This concludes this eyetech.net course on basic refraction techniques.